I guess it's working. Alrighty. Good morning, everyone. Hope everyone's doing well. Sorry, I think I'm reading one of your guys' profile pictures in the mosque. That's hilarious. That's amazing. Oh, that's good. Hope everyone's doing well so far. Just gonna wait a couple more minutes and we'll get started. Again, a lot of technical issues with the live streaming, but I think it's working again. So that means this lecture will be available live as we speak, as well as afterwards. So for all my guys, I want to refer back, and for anyone who can't make it, the live stream is available. I might be squinting a lot today. The eye's just a bit sensitive, so don't mind me. I'm not super tired at all. Just eyes are super sensitive today. Hopefully everyone's having a good morning so far. I know I have been. Today we're going to take a little change in direction as to how I do the class. I want to try this out a bit. We're going to go dive into the properties of bone. So last year, lecture 2, we went to osteology, where we were kind of naming all the bones and where they're located. This time I want to start with a bit more of a background behind the properties of bone. So the building materials of the bone, connective tissue plasticity and what that means, and what's happening at the cellular level for bone, because I think it's fascinating. And I may have told this story before, but one of my professors back at U of T, her name was Dr. Renee Harrison, and she was privileged enough to send live bone cells into space and test what happened when you eliminated gravity. And so that was pretty cool. And I kind of read into her research. I did a research project with her as well. So this is a pretty cool lecture for me to teach as well. Okay, so we're going to get started, guys. And anyone who joins, I'm just going to give them a quick introduction as to what we're doing. Let's see. Perfect. Okay, so like I mentioned, guys, we're going to be talking about bone properties. We're going to be talking about the skeleton. We're going to be talking about the vertebrae as well. We talked last time about the 4 fundamental tissue types that we have in the human body. And this includes the epithelia, so your skin, nervous tissue, so all the nerves, the spinal cord, and the brain of the human body. We got muscle tissue, so the contractile elements, including tendons as well. And we also have connective tissue. And all bone falls under the category of connective tissue. So we're going to dive into that in a little bit more detail today. But other types of connective tissue includes your blood, your cartilage, and we have proper connective tissue, which includes things like ligaments and adipose fatty tissue. All right, so we're going to talk a little bit about the building materials of bones themselves. And when you talk about building materials, you want to start off with the types of cells that we see. And so there are 3 of them, and they all have very similar names with the prefix of osteo, which means bones. So we have our osteocytes, our osteoblasts, and our osteoclasts. And we're going to talk about why they're all important moving on. What a lot of these cells will do is they'll lay down collagen. This is the predominant protein we have in the human body, particularly type 1. And this is fundamentally what bone is made out of, right? And so those are the fibers of the bone. Now, we also have the interfibular component of bone, which is the space around the fibers. Another name for that is extracellular membrane. And this is composed of the mineral salts of the bone. So things like calcium carbonate, calcium phosphate. And this is why we're told to drink a lot of milk when we're kids. Of course, milk is not the only source of calcium. We have the leafy greens. We have other types of vegetables. I know leafy greens are high in calcium. If you eat sardines and you eat them with the bone on, that's a fantastic source of calcium too. You can supplement with calcium as well. I'm not going to recommend how to supplement. There's obviously the problem with too much supplementation. So you guys speak to a naturopathic doctor about how to supplement with calcium properly. But yeah, those are the building materials of bone. And that's what we're going to build our lecture around today. So bone also changes over time. And what we have here is an X-ray image of old bone versus new bone. And I got this out of one of my textbooks that I read a couple of years ago. But you'll see a little bit of a difference between the two types of bone here. So I kind of circled where a fracture occurred between bone A and bone B. The new one's going to be on the left, and the old bone, well, not old, I'd say maybe into adulthood, is going to be on the right. So what we're seeing is a fracture. The younger bone has different properties than the older bone, right? So the younger bone is going to be more like I like to use the twig as an example. So if you ever seen like a twig on a tree that's young and green, and you'll find that when you try to snap it, it's really pliable and it's hard to kind of break. That's kind of how new bone is, right? It's kind of rubbery. Now, compared to older bone's more like this solidified old twig. It's kind of like breaks off. It's like dry wood, breaks off a little bit more easily. That's kind of how old bone is. And the reason why we have that difference is that the newer bone is going to have a lot more collagen, which gives it its flexibility, versus old bone, where over time the collagen will dry out and will be replaced by more mineral salts. So if we go back to the previous slide, those were the two main components that we have in our bone, right? We have the collagen, the mineral salts. Now, when we are young and when we're growing, we have more collagen in our bones. And then over time, as it dries out, it's replaced with more of our mineral salts. Okay. Another main difference between old and new bone is that newer bone is a little bit easier to fix than older bone. So when you do have a fracture, and the two ends are meeting, because collagen is required to help the two ends of the fracture heal, and because the younger bone has a lot more of it, it will be a little bit easier for the newer bone to heal. Well, whereas the older bone, it will require surgical pins to kind of keep it in place. It still will have quite a bit of collagen, but it'll need that fixation to allow the slower healing process to occur. So those are kind of like the fundamental differences, and it's pretty cool that I can kind of show you guys some extra images about how that would look. So again, just a little bit of detail. You see kind of that full fracture over here in this bone. And this bone, you don't have that full fracture. You have more of that fray at one side, kind of like that green twig example that I gave. Okay, so let's dive into connective tissue plasticity. Now, you guys have probably heard of neuroplasticity. We're using plasticity in the same term, right? So plasticity means an ability of anything to respond to a demand, right? So with neuroplasticity, the more you learn, the more you kind of create connections in your mind between the neurons of the brain. With connective tissue, it's kind of the same thing. So connective tissue, like bone, specifically bone, responds to the demand that's exerted on it, right? Of course, there are limits imposed as to how much it can kind of respond to the demand. So things like nutrition, age, and your genetics, right? It's also the reason, so connective tissue plasticity is also the reason why I tell people that I can kind of build a story on them based on what their posture looks like. So, for example, someone that presents with a kyphotic posture like this, I can almost tell that because of the demands of sitting all day, they're probably sitting like this. And so their soft tissue actually accommodates to that. And they kind of formed into this posture. And that's why it's kind of hard to get out of bad posture sometimes. So, but whether you kind of spend most of your day sitting or most of your day running outside doing very strenuous labor, there's always going to be some sort of demand placed on your soft tissue. In the diagrams you see over here, for example, on the left, you'll see a bunch of different tension compression lines on the proximal humor. So this over here you're looking at is the humeral head. So over here we have kind of all the pressure lines that occur on the humerus. And then on the right over here, you kind of see like an internal image of what the bone looks like. So you have the spongy bone that's a little bit closer to the top. Kind of reminds me of spongy toffee. I don't know if you guys have ever had spongy toffee before. And then the more compact bone that occurs on the edges closer to the center of the bone. Okay. Now, if you look at the pattern over here, this is not all random, right? This is all actually determined by the pressures and the demands that are exerted on the femur. And for every single person on the planet, they're going to have a unique set of patterns that are dictated by the demands they put on it every single day. So for every single one of you, if we take an image of your femur, it's going to look a little bit different. And that's kind of fascinating if you think about it. And it's also very important clinically because one of the most dominant types of fractures that we have, especially in later ages, so later stages in life, like your 70s and 80s, are hip fractures, right? So this has important implications as to how can we not only heal hip fractures but also prevent them, right? And most of the hip fractures actually occur at the neck of the femoral head, so right around there. So how do we put demands here over time that could strengthen the bone over here? And we're going to talk about how demands can affect bone properties. But is everyone with me so far? Are there any questions at all? Or is this pretty straightforward so far? Okay. Cool. All right. So moving on. So there's different types of demands we can put on our body. And I've kind of categorized it into an increased demand and a decreased demand, right? So the best real life examples I can use for increased demand are your kickboxer who's using his shin to kick the life out of that punching bag over there you see on the top left, and your ballet dancers who for some reason can manage to be on their toes while dancing, which is phenomenal on its own. And then our examples of decreased demand include the astronaut that just came back from space where gravity was not a thing. And on the bottom right, we have our bed rested patient who is not moving at all. So we're not experiencing many muscle contractions. There's a lot of rest that's happening, not a lot of demand being put in the right way. Gravity is still obviously being exerted, but because of the lack of movement, you're getting a decreased demand that you would normally see in the human body. Cool. So let's talk about the increased demand first, right? The kickboxers have conditioned their shins, and they do this by absorbing unreal impact every time they kick a bag. And they're usually kicking solid objects to like another fighter's shin, for example, right? And over time, their shin just becomes more and more dense and less likely to fracture. Ballet dancers, they have feet of steel. They spend a lot of time supporting their body weight on their toes. The same thing kind of happens there, right? So increased demand is being put particularly in their feet. And so over time, we find that their feet and their toes just become more dense the bone just becomes more solid, less likely to break. And all this demand puts a stress on the bone to cause remodeling. And we're going to talk about how that happens at the cellular level. Okay. Now, with the decreased demand, you have the astronauts who spend months in space. And these guys are, if there's another way to describe them, they're athletes, right? They're super healthy human beings, and they have to be, because going to space, they're denied the privilege of having gravity imposed on them. And gravity is a force that's categorized as 9.81 meters per second squared acceleration. And that's our Earth's mass exerting a force on us, right? All that pull is placing a pressure on our bones. And because of that, our bone responds with keeping a certain density with respect to that gravity that we experience on Earth. Now, when you go into space, because you're denied of that, you're actually losing density over time. And the astronauts will do everything to prevent that from happening. So they'll have their gravity provoking treadmills where they're going to be put into platforms where it will pull their body weight onto the treadmill and they'll run on that. But you can only do that so much, right? So they'll minimize as much as possible. But the moment they enter Earth from a lot of time spent in space, they'll be wheelchaired out. And that's why you have that image over here, this lady astronaut over here that had to be carried out of the spaceship because their bones can lose upwards of 50 to 60% of their density. And that's a lot. So they run the risk of fracture just by that fact. Bed rest is another way to kind of decrease the demand on the body. And in the physio world, sorry, I can give you kind of my experience dealing with bed rest because I used to work in acute care and ICU. And man, I had to argue with my guys that were in bed rest to just move, and rightfully so. I mean, they didn't want to move because they were feeling really sick, very low energy, very low motivation. But it was that constant education about why it's so important for them to have just even a little bit of movement for blood flow purposes, for digestion purposes. But I think, in my opinion, more importantly, to put some demand on the body so that their soft tissue, their connective tissue can respond to it and maintain some level of integrity, right? I would get them to do as little as just rolling from one side of the bed to the other, anything to get their muscle contracting. Now, the added issue with them, on top of the lack of bone density that occurs from bed rest, is the increased stress on certain parts of their soft tissue, particularly their tailbone and their heels, right? Where most of their weight is being exerted on the bed. And so that could lead to problems like ulcers, which can create huge risk factors of infection and increased pain. So decreased demand on the human body is never a good thing. You always want to move. Movement is medicine. In fact, movement is a cure a lot of the time for a lot of problems. So what's happening at the cellular level? Okay. Like we talked about before, there are three types of cells, and we're going to kind of dive into that. Don't get too confused about any of these messenger molecules or any of these little ones. I'm just kind of more concerned about the three different cell types. So we got the osteoclast, we got the osteoblast, and we got the osteocytes. Okay. Now, out of all the fundamental tissue types we have in the body, that is the ligaments, the tendons, the muscles, and the skeleton, a question I often ask, and I may have asked this last year, bless you, I may have asked this last year, is how would you rank them based on how well they heal? So let's say some sort of fracture or tear happens in every single one of them. How would you rate them from best to worst on how they heal? Let's see if you guys can remember, and if not, that's cool. That's totally fine. But let's see where we're at with that. And I guess contextually, you can kind of figure out what might be the best one. But let's see what you guys are thinking for that. And you could do it in the chat section, by the way. I forgot to mention that. Hey, Melanie, yeah, I could always see your guys' names. So anytime you guys chat, you're always going to have your name pop up too. And correct, bone does heal best. What's second, third, and fourth best though? That's what I'm looking for. So again, the four tissue types we have is the ligaments, the muscles, the tendons, and the bones. We know that bone heals the best. And then after bone, what's second, third, and fourth? Let's see what you guys think. No worries, Sarah. That's fine. And you got it, Sarah. So it is bone followed by muscle, tendons, and then ligaments. You guys are awesome. Okay. So this is based on a few factors, of course. Number one being access to blood supply. We know that bone is a storage place for the precursors to blood in the bone marrow, for example. So we know that blood supply is ample. Hydration and cellular activity are both high in the bone. It's also high in the muscle. Muscles are well hydrated. Then you get a little less blood supply to the tendons, so they don't heal as well as the muscle. And then lastly, we have the ligaments. So predominant, like the most common ones that we talk about are the ACL, PCL, MCL, LCL. Anytime you have those kind of strains, they don't heal really well, which is why you typically need to do a reconstruction for a ligament. So that is the hierarchy. Now let's get more into the cells. So like we kind of discussed before, we have the three cell types. The osteoblasts, so the ones over here, we'll call them the builders of the bone, right? So they're the ones that are laying new bone down. The osteocytes are, osteoblasts that kind of became embedded in the bone, and so they remain in that little calcified matrix of the bone, and they're just there for signaling purposes at that point. And then the osteoclasts, we'll call them the demolition crew of the bone. So they're the ones that are more involved in removing up old bone. And we have a careful balance between the osteoblasts and osteoclasts, and that's called an equilibrium. So I'm just going to turn off my phone. That's called an equilibrium, right? So they're constantly, they're both acting and they're both kind of reaching a balance, right? In a healthy body, you have both of them doing just enough work so we're not losing any bone, nor are we gaining too much bone, right? Now, what happens under more demand is signals are thrown at the osteoclast. So osteoclast is the demolition one. That's the one that's resorbing the bone, taking the old bone, removing it. When we put more demand on the bone, these cells, the osteoclast, they get downregulated. So the body's telling them, listen, guys, you can't be demolishing as much bone. Whereas the osteoblast is just chilling, it's doing its own thing, it's still working, and still putting more and more bone on top, right? When that happens, you can imagine that the density of the bone is going to increase now, right? Because more bone's being laid, less is being removed, and so it's getting more and more dense. So think back about our kickboxers and our dancers who put so much stress on their lower extremities. You're getting that down regulation of osteoclasts with them. Now in the reverse is true for our astronauts and our bed rest guys. So when they have less demand, these osteoclasts actually get up-regulated. So their activity increases, meaning they will remove more and more bone versus the osteoblasts, which is still doing their same type of labor. They're still removing the same amount of bone, right? So because of this, because the osteoclast activity increases with decreased demand on the body, now you're going to get less and less density of bone because more of it is being removed, right? So that's a big issue as well. Sorry, I'm just checking the stream, seeing if it's still working. I think it is. Okay, perfect. All right, so This is why exercise is so important, right? And I want to kind of touch base on, okay, we got a question here. Are there other things that can upregulate osteoclasts like steroids? I'm not sure about the steroid effect on bones per se, but I know with the joints, so at the level of the capsule and the cartilage itself, long-term use of steroids can lead to degeneration of the cartilage. In terms of the bone density, I'm not quite sure. But let's say it would affect the bone in the sense that it would decrease its density over time, then steroids would theoretically increase or upregulate osteoclast activity. But I know steroids do have an effect on the joints in the long term, deteriorating the joints. And that's why you'll see a lot of people like bodybuilders have joint pains well into their 40s and 50s, which is still early for a human being, right? So, really good question. But yeah, so in the realm of osteoporosis, which is pretty much another way of saying brittle bones, it's a disease characterized by decreased bone density that is far beyond normal, right? And you have different levels of osteoporosis. You have osteopenia, which is like decreased density, but not enough to cause high risk for fractures. And then you have osteoporosis, which is high risk for fractures as well. The higher risk population is your females in the later stages of life, so 65 and above. Now, I'm always thinking about these guys when I'm thinking about bone density because there's a lot of things that can be done to curtail the effects of osteoporosis, especially earlier in life, right? If you put increased demand through exercise, through strengthening exercises, through impact exercises like gymnastics or jumping or running, these all as a program can decrease the likelihood of fractures in the future in these high risk groups, right? So it's kind of something to think about, and it's something I think about a lot as a physiotherapist is not only treating the injury at hand, but what can we do to prevent future injuries? I think preventative care is the most important thing anyways, right? And in a time like COVID, where, you know, a lot of people are getting infected and have the implications of severe symptoms, I think preventative care is really important even for stuff like that, but it's also relative to our bone health as well. So how can we strengthen ourselves and bulletproof ourselves so things like fractures don't happen in the future? And that's kind of where I wanted to end off with the whole bone property thing because it's really important. Our bones are so dynamic. There's a lot we can do to curtail the effect of aging, of risk for fractures and so forth. Cool. So clearly I'm never on schedule. It's 9:30 already. If you guys want to stay, I'm just going to quickly go through the bones of the human skeleton as well as the vertebrae. And if you guys want to, get going, it's fine. I think I might make this class an hour again. It's just not enough time. Um, but yeah, let's dive into this. And if you guys can't stay, the YouTube live feed is working. So we're good on that end, okay? Cool. So the human skeleton consists of bones, cartilage, ligaments, and joints. We have 206 bones that are divided into two groups. And so we have the color, different colors for the different types of skeleton. We have the axial skeleton, which is, kind of the center of the body where everything originates from. That contains a total of 80 bones. And then we have the appendicular skeleton. So that's where all of our limbs kind of originate from. So the axial skeleton itself consists of the skull, the vertebral column, the ribs, and the sternum that connects the ribs anteriorly, so to the front of the body. The appendicular skeleton consists of both the upper and the lower limbs, and you got your shoulder girdle, which refers to your scapula and its attachment to the shoulder as well as the thoracic spine. And then the clavicles attachment to the sternum. And then we also have the pelvic girdle, which is the pelvis's attachment to the spine via the sacroiliac joint. Okay. Oops. So let's briefly talk about the bone surface markings again. Again, these are fundamentally important to discuss. So we have three different types of bones. Sorry, that's my daughter in the background. I'm on daddy care duties, so if it's too much noise, just let me know. We have three different types of categories. So we have the surfaces that form the joints. We have the projections that are places for muscle and ligament attachments, and we have depressions and openings, right? So at the very top over here, we have the surfaces that form the joints. We got the head. So that's a bony expansion carried out through a narrow neck. So we have the head of the femur, for example, that we saw earlier in the lecture, which is over here. And we have a facet, which is a smooth articular surface. We see those in between the vertebral bodies of the spine. So that's how the separate vertebral bodies kind of connect to each other. We have condyles, which is a more rounded projection of the bone. It's usually at the end of a long bone. So think of your stereotypical bone. The condyles are those kind of bulgy ends to the bones. And then we have the projections, right? So we have a process. Those are any type of bony prominences that come out of a bone. We have tubercles, which are small rounded projections, and then we have tuberosities that are large rounded projections, okay? Again, they always serve as sites of muscular and ligamentous attachments. So for example, the greater tuberosity of the humerus is where a lot of the rotator cuff muscles attach to. And we're going to get into that later on in the course. We have spines, which are sharp, slender projections, and we have the spinous processes of the vertebrae. So those are like those bony pieces of the spine that everyone touches in the back. We have crests. So for example, the iliac crest of the hip. And then we have lines, which are kind of like rough ridges that are along the bones where things attach. So we have the gluteal line, for example, where the glute attaches to the femur. The gluteus maximus attaches to the femur. And then we have depressions and openings, guys. So we have things like fossas, which are very shallow depressions. We have notches, which are really big indentations into the bone. And then we have foramens, which are just holes in bones where things can go through. Yes, baby, I know. I'll be with you in a bit, I promise. Alrighty, let's get into the axial skeleton. So the axial skeleton is comprised of the vertebral column. We have the cervical spine as well as the thoracic spine, the lumbar spine, sacral spine, and we got the coccyx at the very end, also known as the tailbone. So at the very top, we have the cervical vertebra that consists of 7 segments, and they're all named from C1 to C7. The thoracic vertebrae, we have the T1 to T12. So it's composed of 12 segments. And these are the segments of the spine that hold and suspend your rib cage, and they serve as attachment points for your rib cage as well. We have the lumbar vertebrae. This is the lower back region. This is where most of the body weight is accepted onto the spine. And it's also the reason why we have so much density in these vertebral bodies specifically, because most of the weight's being exerted on the lumbar spine, it has to have bigger vertebral bodies and more density to them. So you kind of see morphology being played out functionally as well. We got the sacrum, which is the fused spine. So we have 5 fused vertebrae over here, as you can see. And then again, the coccyx is 4 fused vertebrae. Now, there are certain conditions where you may have the 5th lumbar vertebrae fused to the sacrum, and that's called sacralization, as well as a condition where you may have one of the 5 or the top of the 5 fused vertebrae being unfused, creating a 6th lumbar vertebrae, and that's called lumbarization of the spine. So that's just to show there are some genetic mutations. Well, I guess it's not a genetic mutation. It could be congenital differences between some human bodies, right? The more common is a lumbarization, where you have one of these sacrum vertebral bodies being unfused, creating that 6th lumbar vertebrae. So we also have developmentally what happens with the human body over here. We start with the fetus where the spine's a little more C-shaped, and that's functional for the fetus because that's very protective. They're always trying to be in that fetal position. Their main objective is to just grow, so they don't really need to move as much. And so being curled forward, just protective of everything, is functional for them. Upon birth, you're starting to get some curvatures occurring, primarily at the thoracic. You're getting that kyphotic posture of the thoracic spine, as well as your you're getting more of a lordosis at the sacral spine. So more of that inward curvature. And then when you're a child, you start getting more of the secondary curves. So the cervical spine starts getting a little bit more of that lordosis, and your lumbar spine starts getting a bit of a curvature as well. All right, disorders of the axial spine. So we have a couple of disorders here. Most of you are well aware of this. I've touched upon this before. We have lordosis, which is the far right over here, which is an exaggerated lumbar curvature. This occurs more in certain populations. So people who are pregnant, for example, tend to have this because of the fetus's weight distribution on the body. It pulls the body forward. So it causes a little more curvature in your lumbar spine over here. And that's going to cause a lot of pain in the long run if it's not addressed with proper exercises and positioning of the back. Other people that tend to have this, typically gymnasts and men in the military who are forced to be very upright, very straight. That causes increases curvature in that lumbar spine. So that is what lordosis is. In this position, you'll also find that the abdomen gets stretched out and it's lengthened a little bit. So one of the ways to curtail a lordotic posture is to work more on core control. You get that core nice and strong. It's going to kind of cause a little bit of contraction here, and it will offload that lordosis. It will decrease that curvature over time. Now, on the left, we have more of a kyphosis, which is an exaggeration of your thoracic curvature up here. And this is a bit more common, I find. And it's what we tend to call poor posture in people. So people who work at desks all day are more likely to develop this. It could develop more, particularly in advanced age with women. And because they are at higher risk of osteoporosis that we talked about before, this can cause compression actually in the front, so the anterior portion of their vertebral bodies. So that increased pressure over there can lead to what is known as a compression fracture, because these two ends can be causing too much compression over time because of that increased compression. And, in advanced age, the bone's not able to recover as well. It will lead to that fracture where it becomes a little bit more brittle. Okay, so that's kyphosis. Again, things to kind of curtail kyphosis include promoting extension exercises at your thoracic spine. Things like, for example, the easiest thing I could tell people to do with a kyphotic posture is to take their hands, interlace them, put them behind the back of their head, and just get them to chin tuck and extend through their upper back. If they keep their tummy tucked, that takes the pressure off of their lumbar spine, keeps it neutral, and puts all the pressure through their thoracic spine. And this actually feels pretty good right now because I've been in a kyphotic posture for almost 40 minutes now. So doing things like this, repping it out, can help kind of curtail kyphosis. And it's about giving the body different signals, right? So if the body gets too many signals like this, we talked about it before with connective tissue plasticity, where it will just conform to this and it will get used to this posture, and the body's just going to build itself this way. So to combat that, you need to give more signals of extension through that upper back. And so you give body the ability to now develop posture into that direction as well. So any questions so far, guys? Okay, cool. Pretty straightforward. Alrighty. I think this is our last slide, by the way. Yeah. Okay. let's move into scoliosis. And so scoliosis is another disorder of our axial skeleton, but instead of being an anterior posterior disorder, now we're getting more of a lateral disorder, right? So we have an abnormal lateral curvature where your thoracic spine is curved one way, and typically your lumbar spine is curved the other way. Um, we're really not sure what causes it. Um, it's typically a weaker spine because it wasn't able to hold up in a straight posture during development. Um, Now, with this posture, you can imagine that one side's going to get more compressed. So the joints on one side of the spine are going to get more compressed, leading to pain and tightness. And the other side's going to get more splayed out and weak, right? So that's why scoliosis becomes a difficult problem to deal with. Most people live with scoliosis without many problems, and it's really just a matter of how many degrees of scoliosis you have, right? There's a certain percentage where if you get above 40, a deflection angle of 40 degrees, it becomes something that might warrant surgery. But below that, most people live a pretty normal life. It might lead to more incidences of back pain in the future. Um, Now, with my scoliotic guys, because they have compression on one side and we have splaying or weakness in the other side, the therapy is going to be to create more compression on the side that's decompressed and splay out or open the side that's compressed, right? It's pretty intuitive. So things that are going to open up the lateral line, if you kind of take a look at the video, if you want to open up the lateral line, you want to do things that are going to splay it open, right? And simplistically, doing something where you kind of elevate your arm and side tilt to one side is going to do that, right? Now, on the flip side, if you want to strengthen the side that's splayed out, you might want to hold something that is of resistance with your arm, let's say. So let's say you have a resistance band over here, then doing something where you start in this lengthened position and then you compress and you really pull it down is going to strengthen up that right side that is weak in the scoliosis, right? If that's where the convex portion of it is, right? So there are things you can do to address scoliosis. Now, scoliosis is typically not just a lateral problem, it's also a rotation problem, right? So with a scoliotic posture, you may have a tilt and a rotation. So when the spine is stuck in rotation, you also want to do exercises that will permit more rotation in the direction you lack. So doing things where you can kind of stretch it out over time will help address that rotation deficit in one time, right? And yeah, that's pretty much scoliosis in a nutshell. And those are kind of the things that I would do to address it. Any questions about that? Cool. Okay, so we finished 15 minutes late. I got a question here, actually. So Mujahid's asking, does this happen from birth or does it happen over time? It's a bit of both, right? So it can start at birth, but then over time, if left unaddressed, it will kind of get more and more pronounced in some individuals. It very rarely happens with an injury where you have a back injury and it leads to a scoliosis. So for diagnosis, it's typically left undiagnosed until it becomes really prominent. So it may not, like, I had a couple of my younger clients with pretty pronounced scoliosis, and they were like, I'm trying to remember, 12. I believe they were 12 years old. But it wasn't found until she was 10. And so sometimes it just goes undetected for a very long time, and it's because it doesn't really cause a lot of pain early on in life. Um, the diagnosis is just a physical examination of the spine, right? So you got to look at the curvature and see what's going on. A lot of the times, the spine is not as easy to discern as it is over here in this image. There might be a lot of soft tissue in the way with people that have a little bit more body weight. So you would have to actually palpate each and every segment to see if there's a little bit of that curvature going one way or the other. Another way to kind of figure it out is looking at your shoulder levels and your hip levels, right? So with scoliosis, you will find that one shoulder is going to be more depressed than the other. This is a very severe scoliosis right here, by the way, guys. This is pretty severe. You can kind of tell, you can see that curvature. But by looking at the shoulder levels, you're going to see quite a bit of depression on one side where you have the concave angle versus the other side where you have the convex angle, right? Conversely, if you look at the hip level, you'll notice that on the concave level, at the level of the hip, that's going to be the hip that is elevated, whereas the convex one is going to be the hip that's going to be depressed. A diagnosis typically happens with a physiotherapist, a chiropractor, an osteopath. They're all the specialists when it comes to the assessment of the human body. That's why I don't like to knock doctors, but that's why they kind of never find it. It's not what they specialize in, right? So typically it's found by someone who has a very keen eye for these things, who knows kind of like what to look for in the human body. Even those really little differences make a huge difference in the long run. So you got to get a physiotherapist like myself, or a chiropractor, or an osteopath to kind of really do a proper assessment, take a look at where the levels are with the shoulder, with the hips, if there's any rotation, if one shoulder is more anterior than the other, if there's a little bit of a head tilt as well. You want to palpate the spine, see what's going on. You want to feel the spinal erectors too. So you kind of want to palpate both sides, see if one side's a little bit more hypertonic, meaning the muscle's working a little bit harder than the other. You want to do movement tests as well. So if they're bent this way, guys, you're probably going to find that they're going to have a restriction going the other way, right? Because it's just, they're not used to it. So you want to see if there's movement difficulty going to these different positions as well. So those are very, very minimally what we would look at to assess the scoliosis and plan something based on that, right? But there are a lot of really cool tools that we use to kind of figure out where the scoliosis is, as well as how will we treat it. All right. Can you fix it with surgery? Yes, you can. There are a lot of different approaches. One of my clients went through a pretty new approach last year, sometime late last year. And their approach was to go underneath it was minimally invasive, right? So they cut an incision underneath the abdomen. They moved the lung out of the way, and they actually approached the spine anteriorly. And so if there's an increased curvature on one side, what they might do is they might debride some of the bone. So they'll get rid of some of the bone, and they'll put some rod, some sort of metal rod in between the segments that's very flexible. And over time, the rod, what it will do is it will kind of pull it into place as the child develops, right? The surgery was a success, and they did particularly well with it over time. So there are surgical interventions. Now, they do limit surgical intervention for later on in life when it becomes really problematic, but sometimes they'll do it in the pediatric population. It really depends on the extent of the scoliosis. Any other questions though, guys? I guess I have a question for you, just to get a bit of feedback. What did you think about today's type of format for class? Was it something that was a little bit more different, interesting, getting more into the bone properties and like the cellular activity and more function, get a little bit of imaging as well? Was that a little bit more interesting this time around, guys? Let me know. Or do you guys prefer like just the nitty gritty anatomical terms and stuff, and where things are positioned, where the muscles are, where they originate from, the names of them? All right. Well, we're all done for today. I'll be here for the next 5 minutes if anyone has any more questions for me. Otherwise, next lecture is going to be, oh, perfect. Yeah. So getting good feedback here. Cool, cool. So we're getting good feedback about the real life applications for the materials and the condition stuff. Awesome. Okay, cool. So the next lecture will be Thursday again at 9 a.m. My plan is to get the lecture slides to you guys a little bit earlier and kind of giving you a heads up as to what the material is going to be about. I'm just so bad at getting things done on time, I guess, recently. But I think hopefully next time around we'll have the lecture slides finish early on Wednesday so that you guys can kind of gauge what's going on. And yeah, we'll go from there. Thank you guys so much for tuning in as always. It's a pleasure to teach you. And yeah, we will continue next time. Oh, and tune into the YouTube live if you weren't able to make it today. I guess everyone made it here. If you wanted to refer back to the video, the YouTube live worked as well. Otherwise, no one has any other questions. I hope everyone has a fantastic day. I know we're going into a province-wide lockdown, stay-at-home order, so just everyone stay safe, follow the guidelines, take your vitamin D, and stay active, exercise. Preventative care is more important than anything else, in my opinion. Yes, she just fell asleep. She got so bored of what I was teaching, I guess. Oh, man. No problem, guys. It's a pleasure as always. Have an awesome, awesome week. And we'll reconvene on Thursday. All right. Ali, here, calling it a lecture. We'll talk soon.